Today, we're going to discuss basic concepts of calcifying epithelial odontogenic tumor. It is very rare tumor, accounts for 1% of odontogenic tumors. It is classified as an odontogenic tumor derived from epithelial structures. It is believed to arise from dental lamina or enamel organ structures. Now, calcified areas are seen along with amyloid material. These are characteristic feature of the tumor. They appear as radio-opaque foci on radiograph. Earlier, it was thought to arise from stratum intermedium of enamel organ. But now, most of the researchers say they can also arise from dental lamina. Islands, sheets, or strands of epithelial cells are seen throughout the tumor. As tumor doesn't show carcinomatous features, so it is by and large a benign tumor. It was first reported by Pindborg in 1955 and so called as Pindborg tumor. It is locally invasive. Males are affected more than females, seen mostly in 4th and 5th decade of life. The mandible is affected more than maxilla and it is very common in molar region. Clinical features are it is a painless tumor, there is gradual swelling of the tumor, its consistency is hard, it is well defined or sometimes diffuse, and it causes expansion of cortical plates. The maxillary calcifying epithelial odontogenic tumors cause nasal airway obstruction, sometimes associated with nasal bleeding because proptosis of eyeball and can invade maxillary antrum. Peripheral COTs are seen on soft tissues, mostly gingiva or alveolar region. Your non-specific tumors, superficial or soft, and we have to differentiate clinically and microscopically these tumors from other non-odontogenic soft tissue growths. Radiographically, there is a large radiolucency which can be unilocular or multilocular. Sometimes multiple small radiopaque foci of varying radiodensity are seen. This is also called as snow-driven appearance. But snow-driven appearance is neither characteristic nor common feature of calcifying epithelial odontogenic tumor. Root resorption, pathological fracture of the jawbone is sometimes seen, but it is again not common feature. Histopathologically, epithelial cells are arranged in form of islands, sheets, or strands. Outline of epithelial cells is prominent. Intercellular bridges are seen. There is prominent nucleus and can undergo pleomorphism. The areas of amorphous eosinophilic hyalinized material is seen. It is extracellular in nature, resembles amyloid and so called as amyloid like structure. These areas are dispersed throughout the tumor. This material stains positive with Congo red and thioflavin T and this material appears as apple green when viewed with polarized light. Calcified areas are distinctive features of this tumor. They form concentric rings around degenerating tumor cells, so called as Lisgang rings. They can fuse and usually form large masses. They are positive for hematoxylin stain. Differential diagnosis of COT is amyloblastoma, but we can differentiate or rule out microscopically amyloblastoma. The intraosseous squamous cell carcinoma can be ruled again microscopically or clinically, and adenomatoid odontogenic tumor are mostly seen in the anterior region. They are seen during second decade of life. These can be easily ruled out. As COTs are less aggressive than amyloblastoma, so local resection along with removal of surrounding bone is done. If COTs involve maxilla, then these are treated more aggressively. Some studies, recurrence rate of 15% was found, but overall, there is very low recurrence rate in calcifying epithelial odontogenic tumors. Overall prognosis of these two good. Lastly, coming to some multiple choice questions. Question number one, true about COT is option number A is correct. It is in mandibular region. Again correct. Less aggressive than amyloblastoma. Microscopically calcified areas are seen. So option D is correct. All of the above. Two microscopic features of COT are characterized by sheets of cells are seen. You've got prominent intercellular bridges. There is amyloid-like material which is amorphous hyalinized structure, eosinophilic. There are calcified structures in form of gang rings. So option number D is correct. Radiographic features of Pindborg tumor doesn't resemble any radio-opaque lesion will not resemble a Pindborg tumor. So these options, odontoma, not a lesion, so, and resemble radiographically amyloblastoma, adenomatoid odontoma. Even if odontogenic myxoma has got small honeycomb red compartment, will resemble tumor. These four options, D is the right choice. Prefer option number D here, odontoma. Thank you.